Everyone, I'm very pleased to welcome my good friend, Dr. Richard Geyer. He's the co-founder of the Texas Back Institute and one of the top spine orthopedic surgeons on the planet, in my opinion. Dr. Geyer was instrumental in bringing disc replacement surgery to the United States after it was discovered and used in Europe. You went to the University of Pennsylvania School of Medicine, correct?
Correct.
Did a residency in Parkland in Dallas.
Well, I did my internship there.
Your internship.
And then went back to Penn for residency.
And then back to Penn for residency. That's right. And then you also were past president of the North American Spine Society,
Yes,
and
correct.
recipient of the Volvo Award for Low Back Research.
Yes, I was. You're very good, Dan.
Hey, I did my research. Now, one of the reasons why I wanted to chat with you today is because last week I did an Instagram Live with one of my 19-year-old college golfers named Vinod. And he had a severe L4, L5 disc pathology and was told by two surgeons. He's originally from Sri Lanka. He plays golf in Memphis. And he was told right away at that point, he was 18, he's now 19, that he needed to have a spinal fusion immediately. His teaching pro had sent somebody to me before that I rehabbed. And so he decided to jump on a plane and come and see me. Now, it took me 6 to 8 months of rehab, but I got him back to playing golf. As a matter of fact, right before the COVID stuff started happening to us, he actually had to play 36 and 18 to make it onto the golf traveling team, and he did that. And that was kind of my biggest, fear for him, was having to play back-to-back 18s in one day. So I guess my question is, sometimes we have some success in rehab, sometimes we don't. What could you kind of talk us through the conditions and the signs and symptoms?
Sure.
when we really need to look at going down that surgery route?
Well, Dan, as you know, and you're a great therapist, most patients with herniated disc do not need surgery. Now, a high-performance athlete, they're a little bit different. They're putting more stress and strain on their body. So they really need good rehab. It's not the old, what we call shake and bake, which fortunately doesn't happen anymore. The heat packs, the ultrasound, whatever.
Right.
But the rehab that you do for your patients is really, really important. And if we know that 90%, 80 to 90% of patients with the herniated disc never need surgery, then, to talk about doing a fusion on a young person, especially an 18-year-old, is crazy in my mind. We have many, many patients that have very large herniated disc, and it used to be said by many surgeons, oh, it's such a large herniated disc, you need to have surgery. Now, if the patient is having severe neurologic deficit or they have bowel bladder control, nobody's going to argue that patient should have surgery. But for the run-of-the-mill patient, especially the young person that just has leg pain and doesn't have any deficit, give them a chance to get better, because we also know by following these patients long enough that these disc herniations can resorb. Now, if you're one of the 10 or 20% that doesn't get better with adequate time, anti-inflammatories, maybe an injection, and of course the proper rehab, then that's when you talk about surgery. And
Sure.
It's not a high percent, it's really a very, very low percent. And depending on what the symptoms are, if it's predominantly leg pain, then a microdiscectomy is a good operation for those patients.
Sure.
But to start out with the fusion, unless there's some other pathology, that is an unreasonable thing to suggest. And there's other conditions where you have congenital slippage of one vertebrae on the other, which is called spondylolisthesis, and that, of course, we fuse.
Right. So I find it interesting that you're saying, so you're saying 90% of disc pathologies,
80 to 90.
80 to 90. Why then do you think there's so many surgeries done on disc pathologies in the United States? You think it's just I don't know, because it seems to me that they do more than what you're saying statistically.
Well, Dan, I think it depends on the philosophy of the surgeon. Some surgeons, it's like if you have a hammer, everything's a nail.
Sure.
When I treat a patient, what I'm trying to, I do a couple things. Number one, I use a family test. In other words, if you were my family member, you had a herniated disc, I'm going to do everything I can to make sure that we don't do surgery. Now, if you are a high risk and you're at risk of losing your bowel bladder control, risk of losing your neurologic function, no, we're going to do surgery, and we're going to do it right away. But for those other cases, it really depends on their quality of life. If you can get them through then it's better not to do the surgery, because as good of surgeons as we are, we're still not as good as Mother Nature. Because as I said,
Sure.
I have many, many examples where a patient has a hernia disc, say at L5S1, and they come back to me, 3 or 4 later, and they say, "Doc, it's back again." We get a new MRI scan, and the L5S1 disc is gone, and now they have a new herniation at the L4-5 level. So Mother Nature is our healing mechanisms are just amazing. But again, you don't torture the patient, and it depends on how badly they hurt. If they're really miserable and their quality of life stinks, even if they don't have bad neurologic deficit and they're having severe pain, then no, we don't torture the patient. We say, okay, time to do something.
And let's talk, if you're on social media at all, like I'm and as a therapist, it seems did I lose you? Are you still there?
Yeah, I'm still here.
Okay. It seems as if, younger people are starting to fight more and more back pain, and they get conflicting advice. What kind of advice would you give someone, that's suffering, has had some, long-term back pain, and they still have symptoms? What kind of things would you tell them to look at, to get their relief? Would you basically some of the stuff that you just been saying right now, whether they have ball and bladder problems, whether they have, deficits in their extremities, things like that, what kind of things would they need to look at?
Well, Dan, of course, the emergency things that everybody needs to understand. If you have severe neurologic deficit, and I'm not just talking about numbness, it's really muscle weakness, where you have paralysis of a muscle group or bowel and bladder control. That's an indisputable indication for surgery. But and I see these young patients all the time in their early 20s. Like, I just did a telemedicine on a patient who I think was 28 years old, but it had chronic pain since the age of since he was in high school playing football.
Oh, wow,
and he had been struggling with it, doing, he did therapy, he had chiropractic, he had injections, whatever. And his quality of life was really to the point where he said, I can't do the things I'd like to do. Now, he's not a high power athlete. He used to play basketball in college, but, had to give it up because of his back. And that patient, again, is not having the leg pain, not the neurologic deficit. But we talk about the options for him, and he's not had previous surgery. And, I said to him, it's really your quality of life. If you can't do the things you like to do and you've had an adequate rehab, and I'm really, really, I stress that to the patients. And if you live close to me, Dan, I would make you very, very busy. And I try to send a lot of patients down.
Well, let's talk about when you say adequate rehab. I mean, I'm a physical therapist. I know what's out there. I know what they taught me in school, and in my opinion, a lot of it isn't adequate. But you have people seeking out a physical therapist for help, and maybe they're getting just basic care. A lot of times it's very difficult to get these people what you would call adequate therapy, and I'm kind of at a loss for what to do.
Yeah, I mean, that happens frequently. And I always, when the patients come in and tell me, well, I had physical therapy, I say, okay, describe what they did. And then I'll ask them about core. I'll ask them, all the things that I can do to try to find out. And very quickly, I know whether or not they've had adequate therapy, or it's just been, an extremity rehabilitation therapist that doesn't really know much about the back.
Sure. Well, so let's stay on the young topic for a second. Is it just me, or are younger and younger people having back issues? Is this something that you see, that you've seen through your years, that you're operating on younger and younger people?
Well, I wouldn't say it's a tremendous change, but I think that, we're seeing a lot of the younger, teenagers and the college players, they've been playing sports for a long, long time. And, a lot of it is genetic, but it's also the environment. So it's the genes versus, what they're doing. And when I see an individual in their early 20s or early 30s, typically, and they just have low back pain, not the radicular pain, not a hernia disc, or they may have had a microdiscectomy, say in late teens and early 20s, and that's a pretty common thing. And now they have chronic back pain. If you look back to their history, a lot of them started to have problems in their teenage years. And this is where the genetics comes in. In other words, mom or dad probably had problems, Or
Mm-hmm.
when you question them, they'll tell you that, well, my mom had a fusion at the age of 40, or my dad had a problem. And typically, these patients will say, I used to be very, very active. I can't play this sport. I used to do this and I can't do that. And, they become functionally disabled. So I am seeing more and more of those younger folks like that, that come in. And, fortunately, most of them have, been through, all the usual things. Not all have been through great rehab. So we still try to say, all right, what did you do? Let's try to work on this before
Sure.
you throw in the towel and say, all right, I'm ready for surgery. And, our default is to try to indicate them for disc replacement rather than for a fusion.
So I have a question that I've always wanted to ask you. One of my mentors, Paul Chek, always said you are what you eat. And sometimes he would say you can't make chicken salad out of chicken, starts with an S and it's a four-letter word, right?
We use
Uh,
the same thing.
um, do you see, as a surgeon, do you see any difference in tissue quality from when you first started doing surgery to present day surgery?
No, not well. No, not a difference in tissue quality. I think today people are more geared into being physically fit. And for example, I was doing a telemedicine with a patient. If you saw her, you wouldn't think she's physically fit, but she was 6 weeks out from just a microdiscectomy. She said, "Can I get on my Peloton? Can I start running? Can I do this?" I'm thinking, yeah, but you need to go slow. You haven't done these things for a while. So I think that people are more geared into taking care of their health. And I think a lot of the problems we have today is because we don't take care of ourselves. Just like, with the COVID crisis, the people that get into trouble are the elderly, the people that have diabetes, hypertension, that are overweight. So fortunately, we're seeing people, I think healthier people, although we still see a fair amount of people that eat poorly, that are overweight.
Sure. Okay. Now, this is one of my questions, but you already kind of touched on it. Can you expand a little bit more on your family test? I like that.
Okay, well, my family test, and I started doing this way back when, because when I went through training, I would, follow the doctors around and the people I trained with, and I'm thinking to myself, why in the world is he recommending that? If that was my mother or that was my brother, I mean, there'd be no way. So I think that this helps keep a surgeon honest, because
Okay.
as I said earlier, that there are some surgeons, they don't, whether orthopedic surgeons or neurosurgeons in terms of spine surgery, they don't think about, number one, what's a patient going to be like in the future. So when I operate on a patient, I say to myself, all right, I have to take care of Dan for the rest of his life. I want to get the biggest bang for the buck. In other words, I want to do the operation that takes care of him, but I don't want to do something that's going to jeopardize him as he gets older. At least I want to minimize the problems. And I see this even in my own group. For example, the big thing now is to do this big deformity surgery. And I'm saying big deformity surgery where you're fusing almost the entire thoracic spine down into the sacrum. And these are in younger people. And with our current instrumentation, we can really make a difference. I mean, the x-rays are dramatic, but the problem is if you do it in a 40-year-old, it is just the first in many surgeries that patient is going to have to go through in the future. And that's why, we try to, in my practice, and I don't do the deformity surgery, I mainly do the degenerative low back and the cervical, where, my interest originally started with disc replacement 20 years ago. We try to do motion preservation when possible. Not everybody's a candidate. So it's not like we do an artificial disc on everybody that comes through the door. We can't. We still do lots of fusions on patients. So the family test just leads me to say, what do I want done if that was my brother, my sister, my mother, my father, or one of my kids? And I think that it keeps you honest. And if a surgeon, gets to the point where he can say, well, that's what I want done with me, even though the results and the stats are doing so-and-so surgery says that in 10 years you have a 20 to 30% of another operation, then, I can't help him. But I think most surgeons will be honest.
I think that's beautiful. It's one of the reasons why I love you so much is, again, you really take care of your patients. We just had a question. I knew we'd get one on golf here. What area of the spine do you think is most affected with golfers?
Well, there's no question it's the lower back. And it's the lowest portion of the low back because of the tremendous torque. And you know that, Dan.
Yeah. That's what I figured you'd say. So Now you have some, I know you have patients that when you do their surgery, they're good to go. They return to their activities of daily living or their sport. But I'm sure you've also had some patients that after surgery, maybe they've had a little reoccurrence or, maybe they're not 100% of what you maybe expected. What are some of the factors that guide that? I mean, why do some people have much better outcomes than others when after surgery?
Yeah, that's a great question. It's a question that sort of have plagued us forever. I'll give you a little example. When we were first starting our practice years ago, we looked at all of our microdiscectomies, and we looked at about a couple hundred. And we looked at the difference between people that were hurt on the job and people that were not hurt on the job. Well, we did the same operation, the same indications, and for some reason, people hurt on the job had an inferior result compared to those patients that didn't. So we look at those factors. And then, coming up another 20 years, we started looking at the artificial disc patients. And we looked at our 10 worst and our 10 best patients. And the only difference, it wasn't the x-rays, it wasn't whether they were injured on the job or not. It was whether or not they were working 13 weeks before. So it had nothing to do with anything. I mean, just crazy. So, there's a lot of difference physiologically between the patients. We try to do a good job in selecting our patients properly, but, sometimes the physiology just doesn't work with you. And whenever I have a patient, when we talk about surgery, and if they say, "Doc, can you guarantee me 100% that I'll have no pain?" I said, "I can guarantee 100% that you're not going to be pain-free." Now, some patients do super, and some patients do super, Dan, and there's no question. But the problem is that we can't predict which of those patients there are. And that's what makes my job so interesting, because I see patients from all walks of life. And, when I counsel a patient, I give them not my personal results. I give them, if they would go to the literature and read the results from the literature, the average, that's what I tell them. I say, you have to accept this. And if you get more than that, that's gravy.
Okay, and also then besides obviously a cauda-equina injury or something like that, that's an immediate surgery. Do you always recommend a conservative approach first before surgery, or do you try to?
Dan, the first part I didn't know.
Yeah. So besides like a cauda-equina injury, affecting bowel and bladder, that's a mandatory surgery. Do you always, or do you try to always recommend a conservative approach first?
Well, of course. The fact of the matter is, though, a lot of my patients that I see today, they come from all over the country and they've been through everything. So
Sure.
Those are not the patient where you come to see me, you've had 10 years of problems, you had a couple surgeries, you've been through rehab, you've been through chiropractic. We're not going to say, okay, well, let's try it again. I mean, if they're not a candidate for surgery, I'll tell them that, hey, this is one of those where the treatment is worse than the cure. And
Sure.
It sort of reminds me of what we're doing right now, trying to contain the COVID. Is our treatment worse than the cure?
Right.
So, every patient and individual, certainly if they start out, I rarely recommend surgery immediately. In other words, I want to get to know that patient, and I want them to know me as well. And I want them to buy into the treatment that we're recommending. And I want to see them back several times to say, okay, this isn't working. We tried this, we tried that. You really tried everything. So here are your options. And then we go through and we talk about the reasonable expectations, most importantly.
Okay, so there's a lot of physical therapists watching this, obviously, and so can you talk a little bit about the physician therapist dynamic? Like, what do you expect from the therapist? Is there things that you hope to see from the therapist?
Well, I mean, I'd like to have a relationship with the therapist. We have some therapists in our own practice, and there are a few that I've worked with all the time, and I know, because we've had discussion about our patient, and they'll call me and say, "Hey, Dr. Geyer, I'm just not sure about this. Would you mind checking them over?" And I never have a problem doing that. Or, we're doing this and he's just not doing well. Or, we're doing this and if they're doing great. So I think it's important to have a good relationship with the doctor. I think it is very impersonal for me to write a prescription and to send it to you, Dan, and say, okay, just rehab this patient. Just like the patients that you and I have shared, we talk to each other about, what's going on. And I think, it's better for the patient in the long run, because the patient, number one, has the confidence to know that you're working together as a team. And as I said, I can do the greatest surgery in the world, but if that patient isn't rehab, they're not going to get the maximal benefit from the surgery. And you know that, and you've
Yeah.
seen it in many patients.
Sure. So what type of surgeries do you personally perform?
Me personally, well,
Yes, you personally.
as mostly, I do probably about 50% artificial disc in the low back, and about maybe 60 to 70% in the neck. And again, we try to do the disc replacement predominantly the younger patients, because those are the people that, will go on later in life and have one operation after the other if you do a fusion on them.
Okay.
My obligation to a patient, when I see them, I tell them I'm trying to find reasons why we can't do an artificial disc. And in the neck, we have great long-term data, 10-year data from 3 different artificial discs. In the lumbar spine, we now have 20-year data, and they're not wearing out, they're not failing. And the main difference, at least for the people that are watching and listening, is that when you do a fusion, you have a 10 to 30% chance of requiring surgery at the next level. Now, you might say on the positive side, you have a 70 to 90% chance that you won't. And that's true. It depends on how, what your lifestyle is, and depends on your age as well. But the artificial disc is about 3 to 5% at 10 years and needing more surgery. So, having been pioneers and having seen this, I really think that, and I hate to go back to my scoliosis surgeon, but I really think that we're going to look back in 20 years and say, oh my God, we did all those, we fused all those levels. We'll do some hybrid between some type of motion preservation and fusing just a small segment of the spine, because everything today is going towards more natural treatments. And I don't care if it's natural drug treatment or, through rehab, whatever. What we're trying to do is preserve what Mother Nature gave us. Now, sometimes Mother Nature gives us a bad deck of cards, and we have some, bad disc and whatever, and we got to help the patient.
Sure. Okay, let's shift to kind of a hot topic for me. Let's shift to microdiscectomies. It seems like everybody and their brother is getting a microdiscectomy nowadays. And from my personal experience as a therapist, I see so many people that have come in with microdiscectomies, and they're going down a really bad road post microdiscectomy. What is your opinion on them? Do you do them? What's the outcomes like with microdiscectomies?
All right, Dan. So this is, when you say microdiscectomy, there's about, 10 different varieties. You can do it through the tube. And the problem is, sometimes if it's an inexperienced person doing through the tube, they'll actually grind up the facet joint on the one side. Bad news. That patient, if they have problems in the future, they need a fusion. They can't have an artificial disc. Then you can do
so if they've had that, you can't do an artificial disc. You have to do a fusion.
If they chomp through the facet joint, and, you can't do it. The other type of microdiscectomy is using a microscope through a big incision. Well, that's a microdiscectomy because you're using a microscope. Then you can have a smaller incision and use a magnification. So there's all variations of the theme. Basically, a microdiscectomy, in my way of thinking, it's the smallest incision you can get by with and do the right operation. And you're just removing a portion of the disc. You're trying to preserve the facet joint, preserve the normal anatomy. You're not destroying the muscle. But the reason why it gets a bad name, Dan, I think that it depends on, how long the patient was treated conservatively, depends on their expectations. And the problem is there is a recurrence rate. It's not a huge recurrence rate, but there are some patients that come back and they have a second and a third and a fourth. And we see this all the time. And those are the patients that end up getting fusions or artificial discs, depending on what anatomy is left over.
I'm going to throw this out there. Would you say that there's a big difference in outcomes for microdiscectomies for a non-athlete and a high-performance athlete? Because from my experience, the athletes that are very rotary in nature, the microdiscectomy seems to be kind of like a Band-Aid for what's going to happen in the future, whereas maybe my clients that are just office workers, the microdiscectomy tends to hold over for quite a bit longer time. Would you find that to be the case?
Yeah, I think so. Those patients that, put a lot of torque and a lot of twisting motion in the low back, I mean, they are a setup. Now, I can't tell you scientifically and quote an article that that's the case, but we do know that the recurrence rate after a single level disc, and it ranges anywhere from 8 to 20%, depending on who you read. And part of the problem is that we don't have a reliable way of sealing the disc. There's a new company out that has a material that was approved by the FDA. It's like a little mesh that you can put in there to try to seal it. The problem is that not everybody can you do it. It's very, very tiny, and you have to have a certain amount of normal tissue left over. So until we cure that, we're still going to have problems.
Well, that would be a game changer if they can do that, if they can seal the disc.
Yeah, but the problem is that you have to remember the disc is, some people make the analogy of a jelly donut.
Right.
What I tell patients is it's like the way tires are made. For example, the tires have plies, like 4-ply tire. Well, the disc is a 20 to 40-ply tire, so to speak. So you have the annular rings that go around the outside, and inside it holds the nucleus. Well, the nucleus is a protein sugar complex material that binds water. What happens is if you are predisposed to getting a degenerative disc, maybe from mom or dad, or just your, how much you beat your spine up, the jelly begins to lose its ability to bind water, and then the rings begin to tear. When the rings tear completely, that's when the nucleus comes out. So some patients, I'll say, oh, you have a herniated disc. They'll say, oh, thank God I didn't have a rupture. Well, no, you have a herniated disc because the ring ruptured. So a ruptured disc just means that the ring ruptured. Herniated disc is when the jelly comes out, or the nuclear material. So they're the same thing. So, there's been actually a lot of research going on with stem cells, although not the stem cell crap that you see advertised over the U.S., where they say that we're going to suck out blood from your hip and put stem cells in your disc and regenerate. None of those have been really successful, okay? And in Europe, they've done some studies where actually they can take the stem cells from your hip, culture them to what they think is a meaningful number. Is it 2 million? Is it 4 million? Is it 6 million? Who knows? We can't do that here in the U.S. But in addition to the stem cell, and there's been a couple companies, one is Mesoblast, and there's another company that's also done a study on them that will be coming out hopefully within the next several years. But also there's basic science into actually being able to culture and remake an artificial disc. They've done this in animal studies, and that's really, really exciting. So, someday we're going to be able to inject something into a patient's disc and say, okay, well, we know we have an 85% chance we're going to regenerate. That to me is exciting.
That's fascinating. Okay, so let's go down the line of injections as well. Do you do injections?
I do some. I used to do a lot early in my career, but we have now so many other surgeons, doctors that do them, the pain management doctor, that I just put in my group. So I rarely do them, but I'm very familiar with them. So
a couple follow-ups on that. Number one, what's typically used to inject? Number two, I had a patient one time that had like 17 injections. I would imagine that substance that's being used, that's got to have some sort of long-term effect on the body, does it not?
Dan, a big X. I mean, 17 injections is crazy.
Yeah, I'm not joking. I couldn't believe it.
You're right. And the material we use is called steroid. Your body makes cortisone. Cortisone is a type of steroid.
Right.
Problem is there's lots of side effects with steroids. Steroids can affect your bone density. And 1 or 2 injections, 3 injections, probably not going to make any difference. But you do multiple injections, yes, that can take its toll. The other thing it can do, it can affect your glucose metabolism. So if you're somebody that has diabetes, and I learned the hard way as a young surgeon, I give an injection, the patient come back, they said, Dr. Gar, my blood sugar went up to 300. I said, what? And then I realized after talking with, the endocrinologist that the steroids would bounce their blood sugars way up. So in general, one beef I have with some of my conservative colleagues is that they do injection after injection. I think a rule of thumb, and this is just sort of a common sense kind of thing, if you can't make a patient better after 3 injections, you're not going to make them better after 5, 10, 15, and 17, and you're going to cause more side effects.
I'm so glad to hear you say that. As a matter of fact, you might be getting a client of mine from here that really bad cervical pain, and I've talked him into going for me to get the one because he's lost a lot of function in his left arm. He's in dire pain. And I'm like, listen, let's go get one good. Now, the injection should be done under a fluoroscope, correct?
Correct.
Okay. And, let's get
Otherwise, you
one.
have no idea where you're putting it.
Right. So let's get one injection. Hopefully that goes in the right spot. Maybe it'll buy us some time for rehab. But if that doesn't work in 2 to 4 weeks, then I think you need to be off your way to surgery because they got no space between C4, C5, C5, C6. So for me, the injection is kind of like a means to buy some time for good, proper rehab. Would that be a good way to
Right.
look at it?
Right. What I tell patients when I send them, for example, that patient would need a selective nerve block, either the C5 nerve or the C6 nerve, depending on what you thought. And what it does, it's therapeutic. I want to try to make them feel better so they can do the rehab, but also diagnostic. It tells me that the pain is coming from the C4-5 level or the C5-6 level.
Okay. All right. So let's move on to maybe take a little bit of time, the disc replacement. Now, you are a pioneer in disc replacement. And I guess my first question for you is because I want to talk about one over the other.
Sure.
So one of the patients that I sent to you, you did a fusion on, and then I had to, for weeks I had armchair quarterbacks telling me, oh, you should have had a disc replacement. So I know the decisions that go into whether you have a disc replacement or whether you have a fusion, it's not some willy-nilly flip a coin. What are we going to give them? What are the factors? What are the factors that you look at?
Okay. So as I said, the first thing I look at is this a patient that is a candidate for artificial disc? And we look at a number of things. We look at, first of all, the facet joint integrity. Did they have previous surgery? And how much of the facet joint was left intact? The second thing we look for, deformity. Do they have severe collapse? And do they have a deformity? That's the other thing. What did the disc look like at the level above? And what is the level of where the problem is? And then the last thing, what are going to be the stresses that particular patient is going to put on their spine? In some cases, it's like, well, we'd like to do an artificial disc, but with what you do, there's no way that's going to hold up. And, if it breaks down, then you're back doing a fusion, and then the whole cycle gets, cycles through. Now, on the other hand, if you do a fusion at the lowest most level, it's not a disaster. There's lots of people that have only 4 vertebrae and they have 4 lumbar discs. Right. And the thing is, you can always go back and do an artificial disc at the level above if there's another problem there. But it's not as simple like, hey, I'm going to do an artificial disc on every patient. It's many factors, Dan, and you have to factor in, what I just talked about. And of course, you have to have normal bone density. The facet joints have to be normal. And that's how we managed to have such a good reputation doing these over the 20 years. We learned from our mistakes. We learned that you have to, select the patient very carefully. And as one of my old professors used to say, he'd say, Rick, the 3 most important things to having a successful surgery are selection, selection, selection. You have to be really, really careful about who you select for the operation. And, if you select the artificial disc patient right, they can do marvelous. But we know that, and I'll give you the stats from the artificial disc studies that were compared to fusion. So these are the numbers from the study. So 90% of the artificial disc patients on the average had a 50% reduction of pain, and 90% on the average had a 50% improvement of their functional activities. When you looked at the fusion control arm, the numbers were 80%. We can say, well, 90 versus 80, is it really that much greater? But the difference comes when you look at those patients 10 years out. So the fusion patients will do good, the artificial disc patients do good. But as time goes on, more of the fusion patient will require more surgery at the level above. As I quoted you before, it's somewhere between 10 to 15, even up to 30%, depending on who you talk to. Whereas the artificial disc patient is somewhere between 3 and 5%. So that's the difference between the two.
And one of my colleagues just asked, and I think you answered that, the quality of the vertebra dictates whether you're going to fuse or do a disc replacement. I would imagine if the facets aren't good and the quality of the bone structure is not good, they're going to have to be more down the line of a fusion.
Right. Well, I just saw a patient recently, and he very badly wanted to have artificial disc, and I forget where he's from, Nebraska or wherever. So you know, everything looked good. We got a bone density on him, and his bone density was terrible. And like he was in, I don't know, 41, 42. So it doesn't matter at the age. Patients, even young patients, can have poor bone density. I had a patient even in his early mid 25, and he shouldn't have abnormal bone density. But we learned the hard way when we first started doing these, because we would put them in patients and we weren't really paying attention to bone density, and we would see them collapse or subside. And that's a disaster. We don't want to do that to our patients. And so every patient, no matter how old they are, they get a bone density.
Now, I would assume if you're talking L5S1, because that is the biggest load bearing, I'm assuming that you don't typically do disc replacements down there. It'd probably be more of a fusion.
Well, there's some, there's docs that say that, you know, why do an artificial disc down there? But if you look at all the artificial disc studies, 3/4 of the patients had a disc replacement at L5S1, and they do move. So if we can yet, Dan, we'll still do them. There's a newer disc out, one called the ActiVal, that actually has a little more motion at L5S1 than the other disc. Unfortunately, in the U.S., we only have 2 artificial discs, where outside the U.S., you know, they have about 5 or 6 to choose from.
Oh, fascinating. Okay. And you probably mentioned this before, but I may have missed it. So how long? I mean, could a 25-year-old have a disc replacement and have that disc replacement for the rest of his life? Are they lasting long periods of time?
Okay, well, you know, again, another great question, because when we first started doing these 20 years ago, we told the patients, well, we think they're going to last 10 years, because we were using the total hips as sort of a guide. When they first started doing total hips, they said 10 years. Then they found out they're lasting maybe 20 years, lasting even longer. So we would tell our patients 10 years. And as the years tick by, now that we're 20 years out, we're not seeing any significant wear. Now, it's important for the people listening to understand that they are tested biomechanically in a lab to last the equivalent of 40 years. So they go through 10 million cycles, which is like going backwards and forwards, 10 million cycles, which is what you would do in 20 years. I'm sorry, in 40 years.
40 years, right.
So I tell my patients now, I say, I don't know if they're going to last 40 years, but at least if we gave you motion for at least up to 20 years, we know they're lasting 20 years, then that's 20 more years that you had less stress and strain on the level above. So the answer is about the 25-year-old. Yeah, I've done a lot of young folks. I had a gal, one of my first 3 levels that I did, she was 23 or 24, and I've seen her back at 10 years and now 3 kids and happy and all the rest. So they will last. And even if they go on, you know, the problem with that we don't know is how the spine is going to age. In other words, it's like cardiac disease. You get 1 stent, and then the patient comes back to get a 2nd stent, and then a 3rd stent. But the disc replacement level is not going to go bad. We know that patients can get facet disease, and rarely do we have to do anything about it. Sometimes we'll do injections, cortisone injections, or burning of the nerves called radiofrequency rhizotomy. So it's not that we do a lot of 20-year-olds, but we can do them. And then, again, I have a frank discussion with the patient, their family. We talk about the pros and cons. But if it was my kid that needed either a fusion or disc replacement and they were a candidate for disc replacement, they get a disc replacement.
One of my buddies just asked, what is the most replaced disc that you do? Which one, what level?
The most common level would be L4, 5, and L5S1. 3, 4 is a little less.
Okay.
And then we do a lot of 2-level, and we do 3 levels. Now, they are considered by the FDA to be off-label, but recently we heard word that one of the discs was approved for 2 levels. So off-label just means that, Dan, say you needed a 3-level disc replacement, and we said, all right, Dan, you know, the FDA said it's only approved for 1 level. We know in Europe they do as many as 4 levels, 5 levels, whatever. This is the best thing for you, and that's considered to be off-label. So we can still do it as physicians. It's just the insurance may not pay for 3 levels.
So you've done 3-level disc replacements?
Oh, yeah, I've done a lot of
3-level
disc replacements.
Wow, fascinating. Okay, and then how did like I know my one client had the A-lift and you got to go in through the front and move everything over. How did the procedures for you differ between fusion and disc replacement, or are they similar?
Exactly the same.
Oh, they're exactly the same. So instead of putting a cage in for the fusion, you put a disc in for the disc replacement.
Right.
Okay. And then what about rehab wise? How did the precautions differ from disc replacement to fusion?
Well, with the fusion, it takes between 3 and 6 months before it heals. Whereas with the artificial disc, it takes 3 months before the bone grows into the end plates. In other words, there's two metal end plates, and then in between is the plastic material that allows the motion. So the metal end plates have to fuse to the vertebral body, and that occurs between 6 and 12 weeks. So, for example,
Hmm.
you know, if you're a golfer, and I have a lot of patients that are golfers. So if we do an artificial disc and then we say, all right, first, 6 weeks, you take it easy for 2 weeks, you start to rehab 4 to 6 weeks, and then at 6 weeks, we let you slowly go back to the golf course, with the putting, and then we'll let you do chipping, and then progress through the irons, then driving. And then by 3 months, we let them go. Whereas if they have a fusion, we start that at 3 months. At 3 months, we're pretty sure that the fusion is going to be healed, but we know that by 6 months, it definitely will be healed.
And and you use a cement, correct? You use a type of glue or for the fusion part?
We use a material. It's called a bone morphogenetic protein, and
Right.
what it is a growth substance that everybody has in their bones, except they make it synthetically. They make it in the laboratory animals, and they concentrate it. Not everybody uses it, Dan. It's expensive, but the thing is, in our hands, it is rock solid, reliable. Knock on wood, and I'm knocking on my table here. I've yet to refuse somebody that didn't heal using that material for an anterior lumbar fusion.
So just back. So for rehab time. So if I have a patient with a fusion, you're looking at me not really starting to do a whole lot for 3 months.
No. You're starting at 2 weeks. You can start with some basic core and
Right,
not much
right.
motion, and then at 3 months, then and you work your way up to the 3 month point, and then
Whereas,
after
right.
that.
Whereas the disc replacement, you can start a little earlier.
Yeah, you can start it you can start at 2 weeks, and then at 6 weeks, you can really start to accelerate their activities.
Okay, and I'm going to read a question here. My buddy John Boskill, who was good friends with Dr. Damien Fahey in London, who Dr. Fahey, correct?
I know John.
Yeah. So John says, what advice, I'm going to read this to you. What advice would you give to a recreational golfer who's suffering from long-standing low back or sciatic pain, and on how to find the right kind of practitioner, doctor approach for help? Also, what kind of questions should they ask that practitioner or doctor, and how can they understand if that approach may be right for them as an individual?
Okay. Well, I know Dr. Fahey, and first of all, he is terrific. I would say
He's awesome.
He's my clone. So if you live in England or London area, go and see him. Even if no matter where you live in Europe, go see him. But the questions you need to ask, you need to find out what they think your problem is for sure, and if they're sure it's the disc and not anything else, ask them, why do you think that? And have them show you the x-rays and go over the x-rays with you. And then once you've done that, then, they're going to give you a recommendation, and ask them, what is the advantage of one versus the other? Ask the question, what's the longevity? Will I need more surgery? Is this going to take care of it forever? And, nothing's going to take care of it forever. But you need to ask this question. And then most importantly, if they recommend a surgery, don't be shy. Say, is this a common surgery that you do? Right. And recently, I had seen a patient from Georgia. It was seen by somebody that I trained, and the patient was a candidate for disc replacement. But he said, and the patient said, well, how many do? And he said, well, I do about 10 a year. And she said, okay. And then he came down to me. But those are the questions you need to do, because things are so super specialized today. For example, I've had 2 surgeries, and both times I did my research, and I found out the people that did the most. I went down to Florida for one. I went down to Houston for another. So, I also do medical tourism. And, it's like anything else. The more you do, the better results you're going to have from the surgery, the lower complication rate. Because, for example, with what I do, we have our team. Everybody works together. Yeah. I have the same scrub nurse. In fact, I don't talk to her. I just stick my hand back in, and she watches what I'm doing. She knows what instruments I need. My anesthesiologist knows that what we do in terms of antibiotics and how we position on the table. And, from the lay person, you go see a doctor and think, oh, they all do it the same. No, it's totally different. It's just like athletes, Dan. You have your superstar athletes that, do great. You have your great athletes, and then you have the, the guy that's, sort of a duffer.
I remember Dr. Fahey telling me, and I don't know if he was exaggerating, but he goes, "You got to be careful." He said, "Because you guys have more surgeons in the state of Minnesota than we do in all of the United Kingdom." Is that true?
Well, Dan, I'll give you, for example. So the Dallas-Fort Worth area, we have about 6.4 million people, and there are 250 spine surgeons.
Oh.
So basically, you need one spine surgeon for every 100,000 patients. So you can do the math. We need about 64. So the problem is that, spine surgery, I hate to say this, is a very, very lucrative business. Okay. It used to be. Insurance companies cutting down, and the more docs you have out there, and especially the ones that are trying to put bread on the table, I think that your decision making is affected, and
sure.
It's sad, but we're no different than everybody else.
So I just got a couple more questions. We'll wrap this up. So besides stem cells, which I think have a great future as well, what other breakthroughs do you see coming down the pipe?
Well, as I told you, the laboratory reproduction, or actually manufacturing, biochemically, the artificial disc, as I said, from my alma mater, University of Pennsylvania, they've already done that. They've taken the proper cell combination and the scaffolding. So they take a biologic scaffold to make the annulus, a biological scaffold to make the nucleus, and then they add the cells. To me, that is really cool. I mean, to be able to reproduce, Mother Nature is just amazing. So they're in animal studies. They'll progress through the different animal, lines. They start out with the simplest, and then they go to the more complicated. And then they'll, hopefully, now I don't know if it's going to be 10, 20 years, but eventually we'll be able to do that. I mean, we're getting close to the Star Trek Dr. Spock, where he's going to take his phone and stick it up to your arm. I don't have my phone, but stick it up there and say, "Okay, let's see, Dan, you got a bad disc. Okay, I'm going to inject something. We're going to do it."
Oh, wow. And then two things. I have one of my employees works with an elderly man. I want to say he's 80. He's very active, but he had a fall, and he's been in really bad back pain. It gets to a point when it gets to be that age that the surgery is just you can't do it, correct? Or is it all based on their health and their vitality?
Yeah, it's based on their health and vitality, and it's based on their x-rays. I recently saw a patient, 80 years old, whose back looked much better than mine. He had a single level degenerative disc, and I said, "Oh my God, I can't believe you. I see my back x-ray." So it depends on all those factors. And, also to figure out why he's having the bad back pain too. Make sure he didn't have a fracture or whatever. Okay,
last question. If you could ask people to start doing or stop doing one thing for the good of their spine, what would that be?
Do not bend at the waist and touch your toes.
Do not bend at the waist and touch your toes, really?
Yeah.
Uh-huh.
Because I'll give you a little tip. The back part of the annulus of the disc is the weakest part of the annulus. And when they flex forward, that really puts a lot of stress. So I see all my patients, I tell them, I say, look, sometimes you have to bend. It's okay sometimes. But in general, try to use proper body posture and body mechanics. Squat and keep your back straight. Squat with your hips and knees. Sometimes they have bad knees, so you just flex one knee. But to me, that's the one thing do not do. And keep your core strong. Man, Doc, again, I can't thank you enough. This has been great, and again, I really appreciate you taking the time for us. This has been fun. It's great to see you. It's we belong to the same club. We think the world of each other. Well, again, I really appreciate it. We don't have any more questions that I see off the top of my screen here, so I'm just going to end it here. I know you're a busy man. Please stay safe. And you too, Dan. And hopefully we'll see you in person sometime when all this craziness is over. And everybody that's watching, stay safe. Be very, very careful. We'll lick this, but we have to be smart. Absolutely. Thank you. Appreciate it. Oh, you're very welcome, Dan. All righty. Bye-bye. Bye. Bye-bye.